How's it going, guys? Medium difficulty question for respiratory step 1, internal medicine 2CK. 65-year-old man, chronic bronchitis, worsening shortness of breath over 2 hours, blood pressure 115/70, pulse 90, respiratory rate 30 per minute. He's acidotic, pH 7.21 should be 7.35 to 4.5, PCO2 elevated 78 should be 33 to 44, PO2 low 40 should be 80 to 100, bicarb elevated 33 should be 22 to 28. I purposely left off the normal ranges here because you gotta take your fucking training wheels off. You should know the normal ranges for pH and bicarb. I decided to be friendly, no idea why, and give you the normal range for CO2, okay? So which of the following most likely explanation for the patient's findings? Let's just hop through. Choice A, acute metabolic acidosis with respiratory acidosis, wrong fucking answer. And we know it's instantly wrong because if you had a metabolic acidosis, your bicarb would be low, not high. So the high CO2 makes sense for respiratory acidosis, but this acute metabolic acidosis part makes no fucking sense. Wrong fucking answer. Choice B, acute respiratory acidosis, wrong fucking answer. So although our CO2 is elevated, that makes sense. CO2 is acidic, we're retaining it. Our bicarb would be normal, holy shit, if this is an acute respiratory acidosis, because it takes the kidneys at least 12 to 24 hours to change excretion of bicarb. So for example, you watching this clip, if you were to hold your breath for 2 minutes and you induce an acute respiratory acidosis and we measure your bicarb, it's normal. Okay, you're not going to have any change in your bicarb. So it's when we have the other way around. It's when we have a metabolic disturbance, let's say DKA, where we have a metabolic acidosis, our CO2 can change instantly based on just simply changing your breathing. But when we have the primary disturbance being respiratory, it's going to take a while for the kidneys to change your bicarb. Choice B, wrong fucking answer. Choice C, acute respiratory acidosis with acute metabolic acidosis, wrong fucking answer. So not really much different from choice A, is it? So you clearly can't have an acute metabolic acidosis if your bicarb is elevated. Wrong fucking answer. Choice D, chronic metabolic acidosis with acute respiratory acidosis, wrong fucking answer. I mean, I don't really know what to say. We're going to harp on this point repetitively where we have metabolic acidosis, it can't be an elevation in bicarb. Wrong fucking answer. Choice C, acute on chronic respiratory acidosis, correct answer. NBME writes it just like this. This isn't me trying to be fancy. Chronic respiratory acidosis with acute respiratory acidosis. Diagnosis is exacerbation of COPD, which is always going to be a patient who has chronic CO2 retention. So patients, chronic bronchitis, emphysema, COPD, they're chronic CO2 retainers. So as a baseline, they have chronic respiratory acidosis. So he's probably walking around where he normally has a PCO2 of 50, 55, just giving you arbitrary numbers. He's a chronic CO2 retainer. And then his bicarb is 33. Okay, that's how he normally walks around. He has a chronic respiratory acidosis. And then he could have a viral infection as an example. They want you to know that infections are often what induce an exacerbation of COPD. Even if it's viral, for 2CK in step 3, you actually need to know that you give antibiotics as part of the regimen, okay? Just to take care of any possible infection that's bacterial, but it's likely just a asymptomatic viral precipitant here, okay? And there's no mention of it. And that's going to induce an acute respiratory acidosis on chronic. Now, a challenging detail, some of you who are very astute will note that the respiratory rate is elevated. And you need to know that COPD is the only condition where sometimes, even during an acute exacerbation, even if you've got an elevation of the respiratory rate, you're still going to have an acute respiratory acidosis on chronic respiratory acidosis. So, for example, asthma, during acute asthma attack, pulmonary embolism, you have acute respiratory alkalosis, not acidosis, okay? Students often think that you've got acidosis in asthma and asthma and pulmonary embolism acutely. You don't. It's acute respiratory alkalosis because your respiratory rate is high, okay? So in this case, COPD, it's not the case. Your chronic CO2 retention, you can't get CO2 out, and in the acute setting, even with an elevated respiratory rate, you're still going to have the CO2 retention. So your take-home point here is that for patients who have COPD, they're chronic CO2 retainers. You're going to have a low pH with an elevation of your bicarb. And then if they have an acute exacerbation, can often be viral, but you're still going to give antibiotics anyway as part of the regimen for acute exacerbation. They're going to have acute on chronic respiratory acidosis. You know the deal. Once you make more content, if you like my stuff, subscribe my channel. Appreciate your time. That's it.